Hello dear students, myself Dr. Diana Prem, Associate Professor from the Department of Oral and Maxillofacial Pathology, Vinayaka Mission, Sankaracharya Dental College, Salem. Today my topic is on maxillary sinus. By the end of this presentation, you will be able to describe the structure, microscopic feature, and enumerate the functional importance and the clinical considerations of maxillary sinus. This presentation will be under the following headings: the definition of maxillary sinus, the developmental aspects, the developmental anomalies related to maxillary sinus, structure and variations, microscopic features, functional importance, clinical considerations, and summary. Maxillary sinus was first described by Nathaniel Highmore in 1651 and is called antrum of Highmore. It is the largest of paranasal sinuses situated in the maxilla. By definition, it is the pneumatic space that is lodged inside the body of the maxilla and that communicates with the environment by the way of middle meatus and nasal vestibule. To describe the developmental aspect, at about third month of intrauterine life, maxillary sinus develops from invagination of mucous membrane of the middle meatus, this portion of the nasal cavity. At birth, it is tubular in shape. By 9 years, it becomes ovoid and pyramidal when it reaches the adulthood. The sinus appears to expand and modify in form until the time of eruption of all permanent teeth, and loss of permanent teeth and alveolar bone may make the sinus to appear huge in size, and the maxillary sinus grows by process of pneumatic space. To add a small note on the anatomy of maxillary sinus, the pyramidal shaped maxillary sinus measures 3.5 millimeter anteroposteriorly, 3.2 millimeter in height and 2.5 millimeter in width. It has a volume of 15 to 30 ml. The sinus is described as a four-sided pyramid, the base of which is facing medially towards the nasal cavity and the apex of which is pointed laterally towards the body of the zygomatic bone. This is the base of the maxillary sinus, the apex of which is pointing towards the maxillary zygomatic bone. Coming to the innervations of maxillary sinus, it is supplied by the facial, maxillary, infraorbital, greater and lesser palatine arteries and the lateral and posterior nasal branches of sphenopalatine artery. The venous drainage system is made up of anterior facial vein, pterygoid plexus of veins, and sphenopalatine vein. The lymphatic drainage is through the submandibular nodes and nose. The posterior, middle and superior alveolar nerve, infraorbital nerve and the greater and lesser palatine nerves provides the sensory innervation to maxillary sinus. Now let us discuss on the histological aspects of maxillary sinus. Basically, maxillary sinus is lined with a mucous membrane resembling the respiratory type. The antral mucous membrane is formed of an epithelial resting on the basement membrane. This is the epithelium resting on the basement membrane and a subepithelial connective tissue. This portion is the subepithelial connective tissue. Let us first know the epithelial layer of the maxillary sinus. The epithelial layer of maxillary sinus lining is thinner than that of the nasal cavity. Is very thin. The thickness of the epithelial layer of maxillary sinus is thin than that of the nasal cavity, and it is composed predominantly of pseudo-stratified columnar ciliated epithelial cells, which is derived from the olfactory epithelium of the middle nasal meatus. In addition, The maxillary sinus is lined by the columnar non-ciliated epithelial cells, basal cells and mucus producing secretory globules cells and are also present. The pseudo-stratified columnar epithelial cells, this is the pseudo-stratified columnar ciliated epithelial cells, has a nucleus and a electron-lucent cytoplasm. This is well described in the electron microscopic level. This part is the nucleus and a electron-lucent cytoplasm containing numerous mitochondria, enzyme containing organelles and basal bodies. They serve to attach the ciliary microtubules and to the apical cell membrane. Structurally, the cilia are composed of 9 plus 1 pair of microtubules which provides the mucous ciliary motile function to the sinus epithelium. They beat automatically and are not under nervous control and are genetically programmed. It moves the debris, microorganisms and the mucus film lining the epithelial surface of the sinus into the nasal cavity through the ostium maxillare. The goblet cell. It is a specialized cell that is present in the epithelium of maxillary sinus. This is the goblet cell. It displays all of the characteristic features of a secretory cell. In its basal segment of the cell, it is occupied by the nucleus and the cytocavity network consisting of the rough and the smooth endoplasmic reticulum, the Golgi apparatus, all of which are involved in synthesis of the secretory mucus substance. From the Golgi apparatus, the zymogen granules transports the mucopolysaccharide towards the cellular apex and finally releases this material onto the epithelial surface by exocytosis. Now we will describe the goblet cell. It displays all of the characteristic feature of secretory cells. In its basal segment, the cell is occupied by the nucleus. The cytocavity network consists of rough endoplasmic and smooth endoplasmic reticulum and the Golgi apparatus, all of which are involved in the secretion of secretory mucus substance. This secretory substance from the Golgi apparatus, zymogenic granules transports the mucopolysaccharides towards the cellular apex and finally releases this material onto the epithelial surface by exocytosis. This is the electron microscopic picture of the goblet cell. With this is the nucleus and these are the mucopolysaccharide secretion that is released through the exocytosis. Coming to the description of lamina propria, which is the subepithelial connective tissue layer. It is much thinner than that of the nasal mucosa. It is formed of the connective tissue cell and intercellular substance of collagen bundles and few elastic fiber strands, is moderately vascular. This lamina propria contains subepithelial antral glands composed of mixed glands formed of serous and mucus acini or seromucus acini as well as myoepithelial cells. This mixed secretory product of this antral glands reaches the sinus cavity through the excretory duct. The antral gland are more concentrated in the lamina propria located around the ostium maxillare. With this, we come to the end of the microscopic description of maxillary sinus. Let us now see the functions of maxillary sinus. Maxillary sinus provides humidification and warming of inspired air, assists in regulating intranasal pressure, lightens the skull to maintain the proper head balance, imparting resonance to the voice. It also helps in shock absorption of the head and infiltration of the inspired air. Following are the few clinical considerations which is important for a dental surgeon to know regarding the maxillary sinus. One of the main reasons the maxillary sinuses are especially prone to infection is their close proximity to the teeth, and also because the nerves that supplying the maxillary teeth are those that supply the maxillary sinus, accounting for the dental pain from the healthy teeth arising from the maxillary sinusitis. Bone forming the floor of the sinus can also be the bone surrounding the apex of the tooth. Consequently, periapical infection of teeth can spread to maxillary sinus. The reverse can also occur, with maxillary sinus infection being perceived as pain originating from teeth. Pain from carious lesion or other insults to the dental pulp may be referred to as sinus pain or sinusitis. Accidental communication between the sinus and the oral cavity may occur during tooth extraction or surgical procedure leading to oronatal fistula. Roots of the maxillary posterior teeth may have close relationship to the floor of the maxillary sinus in the following order: first molar, second premolar, second and third molars, first premolar, and rarely the canine. To summarize, the maxillary sinus, due to its topographic location and its functional and systemic association with the orodental complex, results in the transfer of pathologic condition between each other, either by mechanical correction or by the way of blood or lymphatic pathway. And the disease involving these structures may produce confusing systems. Hence, a precise information about the surgical anatomy is essential to a dental surgeon. Therefore, dear students, a thorough knowledge of the anatomical relationship between the maxillary sinus floor and the maxillary posterior teeth is very crucial for the pre-operative treatment planning and performing dental procedures involving the maxillary posterior teeth. Thank you for watching.